I just received one patient from the outpatient department from the medical checkup. He's just come and shown the report to me. In that report, there are two important things. One is his serum creatinine is slightly high, say about 2.5, and urine is showing some protein. And instantly, he said that whether I am having some kidney issues or kidney problem or kidney failure. So, I am stepping into this. I am Dr. Visweswar Reddy, Senior Consultant Nephrologist, Apollo Hospitals, Chennai. So, this patient's age is about 45 years. He is not a diabetic, he is not a hypertensive. Routinely, he underwent some checkup, master checkup, found to be having some creatinine of 2.5. Then, directly from MHC, he referred to the nephrology department. When I saw him first time, first question I asked him, did you have any previous checkup? He said that nothing. So, this is the most important. With diagnosis of chronic kidney disease, which is the most common condition of kidney diseases in our country, is a duration. So, any patient, if the kidney function is low or the creatinine is slightly above the normal for more than 3 months, that is 90 days, we will call it as chronic kidney disease. Then patient is asking, why I am not having any symptoms? Why did he see this my report? So, the most important thing in kidney disease is when kidney function goes down more than 90%, then only you will become symptomatic. So, till that time, only issue is we need to do routinely, go and do the investigation. Then the most important thing is, why should I go undergo investigation? Or in other words, patient is asked, I don't have any issues, why should I undergo investigation? So, any patient, if the family history of kidney problem, or he is a diabetic, or hypertensive, or more than 18 years of age, always should undergo basic kidney testing to see whether he is having normal kidney function or any issues. This is called as screening. The screening is the most important thing in the diagnosis and also in the prevention and the treatment of the chronic kidney disease. So, this patient, as per the report, is showing 2.5, urine is showing some protein, and ultrasound is showing relatively small kidneys. So, this is confirmed because when the kidney size is shrunk or not as expected for his age and size, it goes towards chronic kidney disease. So, chronic kidney disease, once you diagnose, the common question the patient asks is whether we can reverse it. The patient asks whether we can reverse it by taking medication. Once you diagnose chronic kidney disease, three important things should be remembered. One is CKD, that is chronic kidney disease, progressive, permanent and irreversible. Then how to treat that? The next question. Only thing we should assure them, if you have a risk factor, say about diabetes, say hypertension, we need to control those risk factors first. Then they ask, if I controlling hypertension and diabetes, whether I am going to reverse it. We can again assure them, we can prolong your life of the kidney to some extent, maybe 5 years, maybe 10 years, maybe more than that. By controlling the risk factors, we cannot reverse. The first thing we assure the patient is about the diagnosis, assure them, don't panic. Even though it is not reversible, we can increase the kidney life. So, how to increase? I already told, one is control of your risk factors like diabetes, hypertension and diet. So, next question patient asks commonly is, what type of diet should I take? So, diet is, we need to explain in a different way, whether you are vegetarian or non-vegetarian. In vegetarian, most of the patients, no major adjustment needed, except we reduce the protein intake or some potassium in the diet. Usually what we will say is, we will write a prescription and send to the dietitian. If they are unable to understand, again they will come back to us, we will explain. For a non-vegetarian, we need to be a little more strict. Better to avoid red meat. They can take chicken and fish weekly 2 or 3 times, very limited. Limited means we should assure them, no need to stop totally. We need to calculate his body weight and we can give accordingly. Then second question they ask is, how much salt should I take and what type of salt? We will tell them, no need to go for any type of different salts like Ayurvedic salt. You can take a normal table salt, which can give a proportion like 3 grams or 6 grams depending upon his hypertension and other risk factors. Normally, we will advise a low salt, low protein diet for the patients who are in initial stages. Now the next question the patient commonly is whether I am going towards end stage renal disease or dialysis. Should I read dialysis? So basically we can divide the chronic kidney disease into 5 stages, stage 1, 2, 3, 4 and 5, and after that only the patient goes towards the renal replacement therapy. It may be a dialysis, it may be a transplantation. So we will assure them till that time no need to worry about that. We will tell about the dialysis or the transplantation in the last stages like stage 4 and stage 5. At that time we will ask them to prepare, we should prepare the patient for the management of the renal replacement therapy, either dialysis or transplantation. Next common question the patient asks is whether dialysis is lifelong or once you start, how many days I am going to do in a week. We should clearly tell that because chronic kidney disease is an irreversible condition, it is permanent. Once you start dialysis, it must be carried out throughout his or her life, or they can go to transplantation at any stage. Then they can ask how to do dialysis, how many days in a week. The most important thing is we need to create a access. See, dialysis is a simple method where the patient's blood will be filtered, again goes back to the patient. So in this method, the high concentration of toxic waste which are present in the body will be removed in the filter, that's called dialysis filter. So when you are using this one, we require an access. So commonly they ask where to patient the blood is out and how to goes into the patient. We will tell them we need to, temporary patients, we need to put a neckline or in the femoral area, and initially we will start. Or if patient is already knows about chronic kidney disease, we will advise them to undergo a simple operation called AV fistula or AV graft surgery. So this, what is the difference between these two is, this is temporary, we can initiate dialysis immediately. This is a permanent, we require a maturation period of at least 4 to 6 weeks time. So you should be very careful when you explain to this one to the patient, because most of the patients they said, when I am coming to the OP, you start fistula and start dialysis, which is impossible. So what do you tell him? Either you require immediate dialysis, we are going to place a temporary line, stabilize and proceed. Or you know your condition, we will always tell them first proceed for the fistula, once it is mature, go for dialysis. So this is called hemodialysis. There is one method, another method of dialysis called as ambulatory, continuous ambulatory peritoneal dialysis or CAPD. What the difference is, hemodialysis usually we will do in an institute like hospital or daycare centers. CAPD, patient will do himself or herself by his own in his residence. That is different. We will train them how to do the CAPD. The difference is we need to place a line in the abdomen so that they can do the exchanges. Then next question is how to do dialysis in a day or how many hours. We will tell them the basic duration of dialysis, once you start long term dialysis, minimum 3 times in a week. You divide the schedule like alternate days, Monday, Wednesday, Friday, or Tuesday, Thursday and Saturday. Minimum is 4 to or 5 hour duration. This should not miss the schedule. Usually patient should not miss. If you miss any schedule, we need to inform them I missed the schedule so that I can come for next schedule at the earliest. Otherwise they will go into complications. Second thing, same thing they will ask is about CAPD. CAPD, once you start, the difference between hemodialysis and CAPD is continuous. They need to do daily exchanges. Hemodialysis is intermittent. They can do alternate days or maybe in some patients 2 days in a week. Once you start dialysis, we should educate the patient that how to maintain your fistula or how to maintain a CAPD catheter. Fistula, most important thing is you should not take more weight into that one, and encourage them to do some ball exercises so that the fistula will get matured and it will work normally. Similarly, CAPD patients, they can do all activities, but they should sense that whenever they get abdominal pain or that fluid is not coming properly, immediately they should inform. Otherwise, they will get infected or blocked and all going to the complications. Other complication commonly patient asks is, why my hemoglobin levels are coming down? This is a very common question. Almost all patients of ESRD or CKD patients, dialysis patients, hemoglobin levels will fall down. This is because there is one hormone called erythropoietin. The erythropoietin is produced only in the kidney. When kidney function comes down, automatically erythropoietin levels comes down. Erythropoietin is hormone which stimulates your bone marrow to produce RBC. So what we will do, only option is we need to give this erythropoietin artificially from the outside. It is almost like giving insulin to the diabetic patients. For diabetic patients, we need to give insulin 2 or 3 times a day depending upon its control. Here also we need to give, but no need to give on a daily basis. We will give it in a weekly or 2 days twice a weekly or thrice a weekly depending upon the patient's hemoglobin levels. And also encourage good amount of diet. Once the difference between CKD patients without dialysis or patients on dialysis is they should take more protein in the dialysis patients. Mostly the dialysis patients, because of the drug intake, nausea and vomiting, they are unable to take. We will assure them it will settle down. Otherwise, you change your diet pattern so that your muscle mass should increase. So diet is the most important thing. We always should educate the patient, both CKD of dialysis and patients, ESRD patients on dialysis. Then they will tell, once I start dialysis, whether I am going to live for years, decades. We will tell clearly before starting the dialysis to the patient and also its family that dialysis is a supportive system to the kidney. It gives number of complications which are arising out of the kidney failure. It is going to give support, it will reduce the complications, but it is not going to give total quality of life as that of a normal kidney gives. We will assure them. And we will also assure them there are some instances patients living on dialysis 5 years, 10 years, even up to 40 years. But problem is each year they carry a risk of complications or death up to 15%. That means once your patient enters into the dialysis program, for example, say January 1st of 1 year and 31st of December of that year, there is a chance of 50% patient is going to develop complications or death. But if you survive that one, you are going into next year. So this 85% patients who are entering next year, they carry the same risk. But I have seen patients surviving in dialysis up to 25 years. CAPD and hemodialysis almost survival rates are same. CAPD is slightly better, maybe because of the hemodynamic stability. Then the patient asks, if you have a donor, whether I can go for transplantation. See, ideally, transplantation is ideal therapy for the patients of dialysis or the end-stage renal disease patients, because we are going to replace exactly what is the biological function of the kidney by new kidney. But he will say whether I can go for transplantation immediately. We cannot go immediately because there is a workup. First we should see the blood group, second we see who is your donor. So normally we will take the blood group as per the blood transfusion given in the normal blood patients with anemia. That means patient with O group can donate kidney to all the other groups. Patients of AB group can receive kidney from the all groups. Patients of A group can get kidney from the A or O. Patient with B group can get it from the O and B. And O patient should get only from the O. Here the difference is, in blood transfusion we should see A positive or B positive. In kidney transplantation, no need to see positive or negative. If you have A group, A positive, negative, both can donate. That is the most important. We should tell them, because they will ask, my blood is A positive and my donor is A negative, whether she can give. Definitely they can give, there is no issue. And another important thing is, who is the donor? We cannot call somebody immediately he is going to donate, like blood transfusion. It is a solid organ. The donation of this one strictly governed by the government rules. So first degree donation means, which is ideal, mother, father, brother, sister, spouse and grandchildren. These are all first degree relative or the relative donors. What will happen if any of these one are willing to donate and the patient is ready and donor is suitable donor, immediately we can proceed. Usually no need to submit any type of legal, because hospital will decide based upon all the legal documentation. But there are other setup called unrelated. Unrelated means there are again two types. Unrelated, maybe he is related in a different way, like a cousin, uncle, auntie, somebody will donate. These patients also, the donor once you select, will match them first, then go for the documentation and send for the committee. So the difference is, both are relatives, they are all first degree, they are all second degree. No need for committee for the first one, and they require a government committee permission for the unrelated. Unrelated means indirectly for relatives. There is one important thing is, in blood donation, anybody can give blood. That is his will. But in kidney transplantation, there is one term called altruistic donation. Altruistic donation means without any profit, without any selfishness, he is going to donate his kidney. That's called altruistic donation. But the problem with the altruistic donation is we must prove it beyond any monetary profit or benefits. If you prove that one, we can proceed. This is as per the government rules, even the Organ Transplant Act or even the Constitution. But the issue is, even if you have an altruistic donor, we must see very perfectly, legally, without any issues. And if the particular hospital or particular surgeon or particular nephrologist approves, then we can proceed. This is altruistic. Then sometimes the patient asks, I don't have any relative, I don't have anybody to donate. Best thing for him is go for the registration in a deceased donor program or cadaver transplantation. In this, once the patient registered, he can be registered. For example, he belongs to X states, he can be registered in a particular state. Normally, should be available to reach the particular hospital within 3 to 4 hours, which is usually permissible period. Some patients, they can register in different states also, but the problem comes is duration. They should reach the hospital within 3 to 4 hours. So, how to take this registration is, registration process is very simple. Once you know that particular patient's details, there is a system, we will enter all the details in the system. Automatically, the system gives information to the patient and also to the hospital and also the transplant coordinators. Then patient asks, once kidney transplant is over or my donor is available, how long it will take and what are the precautions should I take? The most important thing is, initially once the transplantation over, most important thing is taking the medication. If you miss 1 day medication also, there is a good chance your kidney will be rejected and again you will go back to dialysis. So, the most important thing is, we will assure them, we will take a psychiatrist opinion, a psychologist opinion, ensure that patient should not miss any single dose. In circumstances where he is unable to take, immediately should inform to the hospital or nephrologist. They will take appropriate care in particular time where he is unable to take. Usually transplantation is reasonably major surgery, but we can do leisurely, not an issue. It is an emergency operation. Both donor and recipient will be in same hospital, different OTs. Once you do surgery, the discharge duration for donor is about 5 to 7 days and recipient is all about 5 to 7 days. And sometimes we can do a laparoscopic donor nephrectomy, where the donor at discharge we can do it even 3 to 4 days also. Once the discharge, we will give a different chart, like how many days you should take particular diet and how to see the doctor infrequently. And normally once the transplantation, we will tell them, come 3 days in a week or 2 days in a week or weekly or 15 days, like that, he will come and follow up. So, the most important thing is, first 3 months period is the most important, followed by 6 months and 1 year. Most of the patients, if they survive very well 1 year period, they have very good life. We have seen patients surviving after transplantation even up to 30 years. In fact, transplantation started in 1954, number of transplants occurred. The success rate of transplantation, especially in live relatives, as much as 95% to 98%. So, all these particular one belongs to chronic kidney disease. So, once patient comes to you with this particular problem, we should ensure them clearly that you are in early stage, just assure them, give medication, drugs, diet. If you are in 3rd and 4th stage, assure them that nothing is going to happen. Prepare for the further future of action, something like giving a fistula like that. And once stage 5 is crosses, we are going to for the dialysis stage. And also, once you start dialysis, tell them that these are the methods should follow, either for diet, don't skip schedule, how to make fistula, how to make the catheter of CKD patients, and prepare them for transplantation if the suitable donor is available. So, my suggestion, once you get any patient comes to you or any patient asks question that whether I am having chronic disease, just don't worry, relax, go to the nearest hospital and consult nephrologist. They will give you approximately, and anytime you can contact with the institute nephrologist and they will give the appropriate guidance.